So that will be relevant when you become the clinician, right? And then we'll come to the major part, which I think would be important about the oxygen, delivery systems available in our hospital, wherever you work in the health sector, right? Simple things. And bit about not only simple oxygen, but few things about hyperbaric oxygen also. What are the indications, how we should go ahead, and what are the hazards that you have to be careful about. And then at the end, we'll do few things about uh, hazards of oxygen. Okay, right. Okay, to start with, any idea about hypoxia? What do you think? What do you mean by hypoxia? Please talk. Part of the pain. Anybody can talk, no problem. Rather than me naming people, everybody is free to talk. කාටවත් පේන්න තියෙන ප්‍රශ්නයක් නෑ. Yes, come on. Hypoxia.
Reduce oxygen in the tissue level.
Tissue, that's right. So it's a very vague common term. Hypoxia is tissue level, the oxygen would be less. So tissues may be whole body or it may be part of the body. So it may be, so what it is less oxygen available at tissues. So it may be generalized hypoxia or tissue or localized or regional hypoxia, you could say, right? But when it comes to hypoxemia, is it same or is it difference? What do you think?
Difference. Hypoxemia is reduced oxygen in the arterial level.
Yes. So hypoxemia may be one type of hypoxia that we are going to discuss. Right? So hypoxia means the hypoxia is oxygen availability at the tissue would be low. But one reason of hypoxia, that is oxygen unavailability or less availability at the tissue level, simply maybe because of less available oxygen in the blood. That is mainly dissolved fraction. Right? So hypoxemia, the definition is the availability of dissolved oxygen. So that means the less availability of dissolved oxygen in the patient's blood, which will lead to generalized or localized tissue hypoxia. Right? So you will see people use both terms interchangeably, hypoxemia and hypoxia, but there's a slight difference. And hypoxemia is one type of hypoxia. Right. So what are the types of hypoxia you know? Yes?
Hypoxic hypoxia.
That is hypoxemia, isn't it? Yes. Hypoxic hypoxia, that is tissue levels oxygen may be low simply because the dissolved fraction of oxygen available in blood is low. So that is hypoxemia or hypoxic hypoxemia. Right, okay. Or hypoxic hypoxia. Right, good. One type of hypoxia is the hypoxemic hypoxia or hypoxemia. What else?
Anemic hypoxia.
Yes. The availability of oxygen at the tissue level would be compromised simply because oxygen available in the hemoglobin. You can remember the bulk of the oxygen is available, transported tissues as bound to hemoglobin, isn't it? Only a very negligible amount would be transported as bound to hemoglobin, right? So if the available true that there's a small balance or relationship between the bound fraction and the dissolved fraction, right? So if you can remember the oxygen dissociation curve, that is same about it. The y-axis is oxygen content or amount of oxygen available in the hemoglobin, and the x-axis is something like the partial pressure of oxygen available in the blood. So that is the oxygen dissociation curve. Anyway, so amount of available oxygen at the tissue level will be compromised because of low oxygen dissolved in blood is hypoxemic hypoxia, or hypoxic hypoxia. Availability of oxygen at the tissue level would be compromised because of oxygen available in hemoglobin, that is simply because low hemoglobin. It's called anemic hypoxia.
Anemic hypoxia.
Yeah, what else?
Ischemic hypoxia.
Yes. So ischemic hypoxia is where the however much oxygen available in the blood will not be delivered to the tissues. There is no functional circulation. The transport, if the transport medium is not working. So simply because there's a problem with the pump, or there's a problem at the, or there may be obstruction somewhere. Right? So either it is stagnant or ischemic hypoxia. Either it is because of a problem with the heart, or as a vascular system, maybe because of a block somewhere. Right. So that is stagnant or ischemic hypoxia. The fourth one is
Histotoxic hypoxia.
Hypotoxic hypoxia, where the circulation is good, the pump is good, hemoglobin is fine, the dissolved oxygen is fine, but there's a problem, unfortunate situation at the tissue level, where oxygen cannot be utilized at the tissue level. So if you can remember the oxygen transport pathway, then you'll be able to identify, put a couple of things, abnormalities, described in terms of different types of hypoxia. Right, so it is hypoxic hypoxia or hypoxemia, anemic hypoxia. Then you have the stagnant or ischemic hypoxia. And the fourth one is the histotoxic hypoxia. When it comes to anesthesia, somebody who is undergoing surgery under general anesthesia, right? You will see almost all the patients post-operatively, when they come to the recovery unit after general anesthetic, will be getting oxygen. Correct? So you may have seen it. When you're doing appointment with us, anesthesia appointment, or when you're doing the surgical appointment, your patients who have undergone general anesthesia. When the surgery is over, when they are coming to the recovery unit, once they landed, they would be given oxygen through a face mask for about 10 minutes, 15 minutes, 20 minutes. That is for something to make patients corrected or to prevent somebody going into a specific type of hypoxia at the recovery. Right? So this is particularly related to anesthesia only, general anesthesia only. Nothing to do with medical ward hypoxia or surgical ward hypoxia. Right? That is called diffusion hypoxia. The mechanism is, can you remember the anesthetic gases that we are using during anesthesia? What are the gases that we use?
Fluorine.
Sorry?
Sevoflurane.
That is a vape. Okay, so what are the common gases? Common gases.
Halothane and isoflurane.
Those are vapors, isn't it? True that they are gases. What are the common gases? True gases available during anesthesia.
N2O.
Sorry? What is the most important gas?
Nitrous oxide.
N2O.
Okay, one is nitrous oxide. But if I ask, what is the most important gas? What is your answer?
Oxygen.
Oxygen should be there. Otherwise, you will not be able to. The patient may not be able to survive. Yes. So start with oxygen. We use oxygen 21% now, but when it comes to anesthesia, the oxygen 21% may not be adequate or may not be the ideal mixture that we could use. So we use at least about 35% something, or commonly we use 50%. You could go ahead with oxygen of 35% or plus. The other gas that we use, as you said correctly, is nitrous oxide. So oxygen and nitrous oxide is not a must. Oxygen is a must, isn't it? You can't anesthetize patient without oxygen. You have to have oxygen, right? So oxygen should be there, otherwise you may not be able to get awake the live patient post-op. They may be brain dead. So oxygen is a must, but nitrous oxide is not a must, but it is a historic gas. It will have some augmentation of anesthetic effect. Oxygen will not have any anesthetic effect. Oxygen anesthetic effect. So nitrous oxide will have some anesthetic effect. You may not be able to use nitrous oxide alone to make somebody unconscious. It is impossible. But you could use some vapors, like what you said, like halothane, which is rarely being used now. We commonly use isoflurane in our setup. And in special situation, we use sevoflurane. Right? So those are vapors. Vapors can gases, gas phase in contact with its liquid phase. ඒක නේ vape එකක් කියන්නේ. හරිද? So vapor කියන්නේ ඒතර sevoflurane hari isoflurane or halothane which is in a special gadget called with a device called vaporizer පොඩි tank එකක් වගේ එකක්. ඒතර ඒක ඇතුලේ vapor you can remember that it is available as a liquid isn't it? බෝතල් වල තියෙන වතුරනේ. So you pour it into the device and that wood is very volatile. So, spirit වගේ ටක් ගාලා petrol වගේ වාෂ්ප වෙලා යනවා. It's very volatile. And the volatile phase or the vapor phase, that is the gaseous phase of a substance which is in contact with its liquid medium, is a vapor. So that could be used, and nitrous oxide will have an additional effect of anesthesia with vapors. So oxygen plus or minus nitrous oxide plus anesthetic vapor. The problem comes with the nitrous oxide. Right? We commonly use nitrous oxide as a historic agent because it has some advantage. But what's the problem? Because before you make the patient exposed to nitrous oxide, the patients are exposed to oxygen and what else? What is the other gas? What is the other gas now you are exposed to at your home? Oxygen and
N2.
Nitrogen, yes. Oxygen and nitrogen. So everybody is on oxygen, nitrogen, and nitrogen, you know, it's not being used at all. It's an inert gas. The environmental nitrogen may be in equilibrium with allular nitrogen, will be in equilibrium with bulb and tissue nitrogen. So there's not been nitrogen, it's not been used anyway. But when you make the patient unconscious by turning from oxygen nitrogen mixture to oxygen nitrous oxide mixture, but my point, from oxygen nitrogen to oxygen nitrous oxide mixture, there's an issue, there's the competition between nitrogen and nitrous oxide. Oxygen is anyway common. We have environmental 21% and now we are giving 35% or 40% of oxygen at the anesthetic level. But the difference is nitrogen and nitrous oxide, right? So it is found, the usual fact that everybody knows is the nitrous oxide is very, very soluble and diffusible compared to nitrogen. So when you expose the patient to oxygen nitrous oxide straight away, stopping nitrogen, that is blocking the patient breathing on atmospheric air, now on anesthetic gases, oxygen nitrous oxide, the nitrous oxide may be at a higher concentration from the anesthetic side. And nitrogen may be high at the patient's tissue level or blood level. So there will be the movement in and out at the alveolar level. So nitrogen may be coming out and nitrous oxide may be going in, right? And patient would be denitrogenated at the end and patient would be on throughout the operation oxygen and nitrous oxide, right? Nitrous oxide is metabolized partly and partly excreted, partly the exhaled, right? The issue comes at the end of the operation. At the end of the operation, if you just make the patient breathing atmospheric air, that is you cut off the oxygen and nitrous oxide mixture and allow the patient to breathe on oxygen and nitrogen, the reverse happen at the alveolar level. The nitrogen available in the environment is very high compared to the alveolar and blood, and nitrous oxide available in the tissues and blood will be very high compared to the atmosphere. The atmosphere doesn't have any nitrous oxide. So the reverse movement at the alveolar will happen at the end of the operation. So if you allow the patient to breathe on just 21% oxygen with 78% nitrogen, that is atmospheric air, the speed of nitrogen diffusing into the alveoli and then the bloodstream and tissues is far less than the nitrous oxide diffusing out of the tissues, blood to the alveoli. The nitrogen and atmospheric nitrogen alveoli ඇතුලෙන් the bloodstream එකට diffuse වෙන වේගයට වඩා වැඩි වේගයකින් nitrous oxide then the tissues වල patient ගේ blood concentration එක වැඩි nitrous oxide diffuse වෙනවා alveoli එකට මොකද concentration gradient දැන් දෙපැත්ත අනිත් පැත්ත මාරු වෙලා තියෙනවා. So what will happen? The nitrous oxide, the nitrogen is there, environmental nitrogen, ඒක slowly ඇතුළට යනවා patient tissue bloodstream, nitrous oxide at a very fast level flooding into the alveoli. What will happen to the alveoli? Alveoli would be partly swollen with gases. But what will happen to the oxygen? What will happen to the oxygen? Now there's a mixture, oxygen, nitrogen, and nitrous oxide. What will happen to the oxygen? Yes? What happened to the oxygen? In the alveoli level. Come on. Yes.
Reduce oxygen diffusion to the alveolar capillary.
What happened to the simply oxygen? What will happen to the oxygen partial pressure? That's what I'm asking.
Reduce.
It will reduce.
Reduce.
It reduce. ඇයි ඉස්සෙල්ලා oxygen nitrogen තියෙන එක දැන් තව එක්කෙනෙක් කරලා. alveoli carbon dioxide තියෙනවා. That is usual. So we have oxygen, nitrogen, and carbon dioxide now. ඊට අමතරව then we are getting a nitrous oxide from tissues also. So carbon dioxide would be diluted. Nitrogen would be diluted. Doesn't matter. But oxygen also would be diluted, which matters a lot. So that is called diffusion hypoxia. So it is simply because of the nitrogen and nitrous oxide interaction at the end of the operation. So what we could do is to prevent that low FiO2 at the partial pressure of oxygen at the alveolar level. So that is again maybe a partly of a hypoxia situation actually. It's a different type of hypoxia because the amount of blood available amount of oxygen available to the diffusion into the alveoli and to the alveolar bloodstream may be low. So it's a type of a hypoxic or hypoxemic, the hypoxia or hypoxia. So to prevent that, we always make sure we give at least 40% of the oxygen, not 21% of oxygen post-operative, to minimize that oxygen dilution. Got that point? Is it clear?
Yes, sir.
Yes, sir.
So that is diffusion hypoxia. Right? So it is actually a type of hypoxia. Right. So those are the types of hypoxia that you know of. Right. If you come to the oxygen transport, we are going to discuss now. You may be able to remember this one, right? We just had a I had a small document available here to show. Make a share screen here. Share screen again. Whiteboard. Go to that exit. Can you see this document?
Yes, sir.
Right. So this is how the oxygen, how to calculate the oxygen content, or ultimately the oxygen delivered to the tissues. So you can remember the two ways of transport of oxygen, which is oxygen bound to hemoglobin. The second one is oxygen dissolved. But you can remember the hemoglobin will be the bulk transport, correct? It would be the bulk transport, and oxygen dissolved is very, very negligible. So how do we calculate? If you want to calculate the amount of oxygen available in hemoglobin, and this is the formula that we use. We should have the hemoglobin concentration that is coming as grams per deciliter. It may be 12, 13, 14, whatever the hemoglobin concentration available in 100 ml blood, hemoglobin grams. Then we want the value of oxygen saturation of hemoglobin. What does it mean? What is the percentage of hemoglobin saturated by oxygen? Hemoglobin has 4 molecules, 4 heme moieties, ඒකට 4ක් හම්බ වෙනවා oxygen, right? So it can the one hemoglobin molecule can bind maximum of 4 oxygen. But at the end of the day, we should have a value of how much each hemoglobin or the total hemoglobin is bound. What is the percentage of oxygen saturation of hemoglobin by oxygen? And this constant value of 1.34 ml per gram. This is a constant. The people have found out from research. The actual one is 1.39 ml of gram. That is usual oxygen molecule. If you take the molecule away, 1 gram of hemoglobin will be able to bind 1.39 ml of oxygen. 39. But it has reduced to 1.34 because not everybody is having similar type of hemoglobin all the time. There may be a small amount of carboxyhemoglobin. There may be a few very slightly amount of methemoglobin. So there may be some odd hemoglobins also available. 1.39 we are not 100% sure about it. So they have come to a compromise saying 1.3. But hemoglobin gram ekakma could bind 1.34 ml of oxygen. කොච්චරක් hemoglobin oxygen වල saturate වෙලාද? කොච්චරක් oxygen available. So දැන් මේක සුළු කරාම you will get a value of මේ උඩ ග්‍රෑම් වලට මේ යට ග්‍රෑම් කැපෙනවා. උඩ ml ඉතුරු වෙනවා යට ඩෙසිලීටර් ඉතුරු වෙනවා. එතකොට එන්නේ මොකද්ද? ml of oxygen per deciliter of blood. හරිද? Got that point?
Yes, sir.
So when you select the hemoglobin is gram per deciliter, oxygen saturation has no unit, it's a percentage. 1.34 කියන්නේ එක oxygen gram එක කොච්චර hemoglobin oxygen bound කරගන්න පුළුවන්ද? right? ඒතර මේක සුළු කරාම මේ unit stick කැපුවාම අන්තිමට උඩ gram වලට යට gram යනවා. ml උඩ තියෙනවා, deciliter යට තියෙනවා. ඒ කියන්නේ per deciliter වෙනවා. එතකොට oxygen bound hemoglobin will come as milliliters per 100 ml or deciliter. Right? Milliliters of oxygen per deciliter of plasma or blood. So that is the amount of oxygen bound to hemoglobin. That is the majority. Then we have a small amount which is negligible but most important. Oxygen dissolved. For that dissolved fraction we need this value. This is called partial pressure of arterial oxygen in millimeters of mercury or kilopascal or whatever. And there is a constant. If you can remember, the amount of dissolved, whatever the gas dissolved, would directly depend on the concentration, right? එතකොට concentration එක වැඩි වෙන්න මොකක් හරි medium එක dissolve වෙන fraction එක වැඩි. Direct the relationship එකක් තියෙනවා, right? So oxygen dissolve will be directly dependent on the partial pressure of the oxygen available or in the tissues, right? And this constant is called a solubility coefficient of oxygen in blood. Solubility coefficient of oxygen in blood. That comes as a value of milliliters per milligram per deciliter. Sorry, so per milliliter millimeters of mercury per deciliter. දැන් බලන්න මේක සුළු කරාම ආයිත් එන්නේ වාට ml උඩ තියෙනවා. යට තියෙන ඉර යට තියෙන millimeters per millimeters of mercury, උඩ millimeters of mercury වලට කැපිලා යනවා. ඉර යට තියෙනවා deciliter. So it become per deciliter. So dissolved oxygen would be coming as again milliliters of oxygen per deciliter of blood. එහෙම නැත්නම් 100 ml of blood. හරිද? Clear?
Yes, sir.
Yes, sir.
Right. So 2 points. Oxygen bound hemoglobin, oxygen dissolved. Usually the amount of oxygen dissolved in blood is 3 ml per deciliter. ඒක තමයි සාමාන්‍යයෙන් අපි at rest. දැන් ඔයගොල්ලෝගේ බැලුවොත් දැන් මෙතන කිසිම ස්ට්‍රෙස් එකකුත් නැහැ, කාටවත් පේන්නෙත් නැහැ, ඒක නිසා බයකුත් නැහැ. So at rest now. So the amount of oxygen dissolved, if you are breathing 21% oxygen, roughly about 3 ml oxygen, 3 ml of oxygen dissolved in 100 ml of blood or plasma or deciliter, right? But at rest, tissues would need, if you take generally, tissues would need about 60 ml of blood for their the metabolic activity. Oxygen වැඩිම utilize වෙන්නේ කොතනද cell වල? Where? Oxygen ultimately being utilized where?
Mitochondria.
In the mitochondria. Good. In the mitochondria. So oxygen is dissolved in the mitochondria. For the tissues, whole body, if you take whole body at rest, we need about 60 ml of oxygen. So අපිට 3 ml හම්බ වෙන dissolved fraction එකෙන් ඉතුරු ඔක්කොම ටික හම්බ වෙන්නේ කොහෙන්ද? Oxygen bound to hemoglobin. එතකොට bound form මේකේ dissolved fraction එක අඩු වෙන්න because dissolved fraction would be diffused into the tissues from blood. මේක අඩු වෙන්න hemoglobin bound වෙලා තියෙන oxygen bound to hemoglobin would be slowly move to the dissolved fraction and would be the dissolved to the tissues again. So 3 ml would be available ml of oxygen available in each 100 ml of blood as dissolved fraction. Rest may be about 50-55 ml of oxygen would be provided by the oxygen bound to hemoglobin. Right? Roughly about 60 ml of oxygen is needed per deciliter of blood to the tissues to run the basic function at rest. Right. So those are the two things. So if you want to get the oxygen content, then the summation of both oxygen in hemoglobin, oxygen dissolved. So if this is the amount of oxygen available in ml per deciliter of blood. Right? But if you want to calculate how much oxygen would be delivered to the tissues as a rate, then we have to make sure we have to incorporate that cardiac output into the scenario. This is deciliter එක තියෙන oxygen ප්‍රමාණය මේ තියෙන්නේ. ඒ වගේ deciliters කොච්චරයක් යනවද per minute? Right? මේක තියෙන deciliter එක තියෙන oxygen. Deciliter එක තියෙන oxygen bound to hemoglobin and dissolved. ඒ වගේ deciliters කොච්චරක් යනවද මිනිත්තු? So deciliters per minute you could say, not the milliliters, deciliters per minute in the cardiac output. And when you multiply that, then you will be able to identify the oxygen delivered to the tissues could be calculated. So it may be about 700 to 1000 ml of oxygen would be delivered to the tissues per minute. Calculate කළ බලන්න නිකන් හම්බුනේ කියලා, right? How much oxygen would be available. So this is the oxygen delivered to the tissues. So then මේක දිහා බැලුවාම අපිට හිතා ගන්න පුළුවන් all the types of hypoxia. So this is anemic hypoxia. This is hypoxemic hypoxia or the hypoxemia. And this is what? Ischemic or stagnant hypoxia. And this is not in the histotoxic hypoxia is not available in the oxygen delivery because there's no problem with oxygen delivery to the tissues in the histotoxic hypoxia. There's a problem with the tissues itself. Right? Clear? Oh, did it?
Clear, sir.
Yes, sir.
සමහරු දීද මන් දන්නේ ලෙක්චර් එකේ අඩුවන්නේ right. Okay, we'll come back to the again. Right. So that is about the oxygen transport. Right? So we go to the next one. Tell me, what are the common indications that you have seen? Okay, before that, so we have discussed about the hypoxia by concentrating on the oxygen delivery equation එකක් හදලා ඒ equation එකට අනුව then we categorize types of hypoxia depending what has compromised, right? So how patients present? How do you know somebody is hypoxic? Tell me what are the clinical features that you would expect. Symptoms.
Dyspnea.
Sorry.
Dyspnea.
Okay, good. Patients would be dyspneic. They say they can't breathe, short of breath, right? So dyspnea is a sign that you will write on the BHT saying on examination patient is dyspneic. The patient will come and tell you, I'm short of breath, can't breathe, difficult to breathe. Okay, good. What else?
Tachycardia.
Patient would be the tachycardic again would be a sign. Okay. Any other thing the patient would tell you?
Lethargic, sleepiness.
Okay, patient would be a bit sleepy, but before sleepy, the sleepiness or sedation or that type of thing would be a little late, but
Irritable.
Patient should be irritable, okay, and so that is restless, and they will be anxious. When you look at it, they will be anxious. Okay, good. What else? Dyspnea එක තව මොකක්ද දෙන්න පුළුවන්? They would be dyspneic at the same time. They would be ඒකත් එක මොකක්ද අනිත් එක?
Coffee.
බන කතා කරන එක. Common things. If you are dyspneic, what is the next thing that you will expect all the time?
Tachypnea.
Patient would be tachypneic. Yes, patient would be tachypneic. Right. So patient would be dyspneic, complaining of short of breath. Tachypneic when you examine, they would be restless, anxious. Somebody said patient would be tachycardic. Yes. What else? Then patient would be
Sweating.
possible. Okay. It's not a common feature, but it's possible. Any other things? Any other cardiovascular thing that you could expect apart from tachycardia?
Cold peripheries.
Okay, maybe because of hypotension.
Poor exercise intolerance. Poor exercise intolerance.
Okay, how do you say in this case? Patient will not say no. Who exercise tolerance? What the patient would tell you? Patient will complain. Point is correct. I am taking your point, but tell me in what exact explanation they will say.
Fat.
Huh?
Dyspnea.
Thank you. Hello. Then they will say dyspnea.
Dizzy.
Okay. Your colleague said patient is having a poor exercise. How they would say, doctor?
Fatigue.
Fatigability. Yes. Fatigable. Very fatigued looking. Yes. So that may be a symptom patient would say. හුස්ම ගන්න අමාරුයි, හරිම මහන්සි වගේ. නේද? හරිම නිකම් uncomfortable feeling එකක් තියෙනවා. And then you examine. Yes, you will have tachycardic. They may be hypertensive, later hypotension. They may be having tachycardia plus any other arrhythmia is possible. Tachyarrhythmias. Right? ECG changes possible because of tachycardia and hypertension. Those are possible. Then there are a couple of neurological features. Initially, patient would be anxious, restless, but then would be confused. But you are happy with the patient's confusion, then patient might go into coma. Even fits is possible. Fits are possible. Right? So there may be respiratory, cardiovascular, and CNS symptoms and signs to suspect. Because of the hypoxia itself, the reduced oxygen at the tissue level itself, that the direct effects would be your CNS effect that you said, this confusion or what you said about the sleepiness and all those things. Hypertension may be a direct feature. Myocardial depression may be a direct feature, which will make the hypotension. But indirect features of hypoxia would be the prominent one to start with. Hypoxia will stimulate, you can remember, the carotid and aortic bodies, chemoreceptors. එතකොට ඒකෙන් stimulate කරන sympathetic system. That's why patients are tachycardic, tachypneic, hypertensive, ECG changes, all those things possible. So remember that there are a couple of symptoms and signs. The hypoxia acting indirectly on, so acting on chemoreceptors and causing symptoms and signs are more prominent than hypoxia affecting directly to the tissues. How can we manage? What are the steps in management of? If any other thing, cyanosis, would it be a common one, or what do you think? Kok කියන්න? Cyanosis detect කරගන්න ඕන මොනවද prerequisites? Cyanosis කියන්නේ what is cyanosis? Yes, come on.
5.
ඇයිනේ? අයියෙන් කියනවා මම මගේ මේක වැඩි කරාද කියන්නේ?
Presence of desaturated hemoglobin more than 5 grams per deciliter.
Hemoglobin should be available at least more than 5 grams. ඊට hemoglobin අඩු වුණොත් desaturation එක පේන්නේ නැහැ. You can't identify cyanosis in that. So that is a problem. You need hemoglobin of more than 5. ඊට වඩා anemic උන්ගේ cyanosis බලලා වැඩ. But will it be a cyanosis would be a early feature of hypoxia or late? Or are you expecting somebody to develop cyanosis to detect hypoxia and then to decide treatment? What do you think? Yes or no?
It's a late one.
Sorry, it's a late one. Yeah, it's a late one. So you should never wait cyanosis to develop to decide or to start treating. So it's a late feature. And if you are in the patient is in the hospital, you could easily use a pulse oximeter. That will tell you how much of oxygen available in hemoglobin as a percentage. That will indirectly tell you some clue about hypoxia. But remember, pulse oximeter will take some couple of minutes to detect hypoxia. So that is a good one, but it's not the ideal, best one to identify immediate acute hypoxia. But pulse oximeter could be. If you have the facilities to do a blood gas, then you could do a blood gas and see how much of oxygen available in the tissue, that the blood level, the dissolved fraction, as well as the hemoglobin fraction. Both could be detected in the blood gas. So a couple of bedside tests also could be utilized to identify somebody hypoxic. So there are symptoms, signs, and bedside tests. Okay. Okay. How do we manage? What are the broad or basic common steps that we could use to manage somebody suspected of hypoxia? Can you එක දෙක තුන? කියන්න ගොඩක් තින්ද මට හොස්පිටල් එකට නැත්නම් මේ පෝස්ට් කැෂුවල්ටි. දැන් මම මේ ස්ක්‍රීන් එක බෙදලා එක එක්කෙනාගේ නම් කරනවා. එතකොට තමයි ඔන්න ප්‍රශ්නේ වෙන්නේ. කමක් නැද්ද? So a couple of, there are 104 people here. මේක ස්ක්‍රීන් එක බෙදලා නම් කරොත් අන්න පුළුවන් එතකොට. කතා කරන්නේ නැත්නම් ගොඩු වගේ ඉන්න නෑ. Yes, come on, here, please. What are steps? Can somebody start? එක්කෙනෙක් පටන් ගන්නවා අනිත් එකක් කියයි. Nobody speak. Jivanta, yes. Jivanta screen එකට ආ. කියන්න බෑ. Yes, start. Clear නෑනේ දරුවෝ. මොකක්ද මන්ද මගේ කම්පියුටර්? කවුරු හරි මේ ෆෝන් එක
starting ABCD approach.
Okay, right, all right. So you start.
The airway is clear.
Okay, make sure the patient's airway is clear.
ABCD approach.
Okay. If you is my suggestion. If somebody asks, how do you manage this patient? Rather than ABCD approach as your first sentence, keep it in mind that the approach should be ABCDE. And then the question is, how do you manage? So it's a practical answer that you should give, isn't it? It's a practical answer that you should give. So rather than saying I'm following ABCD approach, it has nothing, no sense. Keep it in mind, the management line should be ABCDE. Then you tell the examiner, this is what I'm going to do. Okay, I'm going to see whether patient's airway is clear. Right? Patients should be sedate when confused support kala dila. There may be secretions. In that case, I could suck out secretions. What else? Yes. When it comes to B, A wala kaam gut karan pulan deyatti wala. Koko kiyanna. Narmada, yes. Any other thing that you could do?
Sir, I couldn't get the question.
Good. The question is, what are the steps in managing a patient suspected of hypoxia? Harida? Thank you, Anba. Sanjeevanta said he is going to manage with A, B, C, D, but I said rather than telling A, B, C, D, you keep it in mind the approach is A, B, C, D, and what you should do. Okay, I'll go to the patient. If there's no probable history available at the moment, short history, quick examination about the parameters. Right. I'll connect the pulse oximeter, see how is the oxygen saturation. Right. Make sure patient's airway is clear. Suck out the secretions if secretions are available. Then what I'm going to do? Coming to B. So pulse oximeter is better at the A, level A. Harida, Jeevanta, got it? Yeah. Then B.
Yes.
Anything else about the B? Anything about B?
Assessment by look, listen, and feel.
Okay, right, all right. So patient's breathing is not that adequate, you mean? Because patient is very bradypneic, struggling to breathe, like, what can you do then?
Start with the high flow oxygen.
Yeah, you could start high flow oxygen. And start high flow.
Not
If
really.
the patient's breathing is not adequate or patient is struggling, then you could support the patient's breathing. You can support the patient using a bag valve mask connected to the oxygen. Right? So make sure that you get a short history examination, confirm it, put a pulse oximeter, make sure patient's airway is clear, suck out secretion if available, make sure patient is comfortable position, because if somebody is hypoxic, the classical position would be, they will say they can't lie down, isn't it? They will always try to sit on the bed and try to keep their arms on the patient's, his or her, the legs, and try to breathe. So that is the position where they will be able to get the maximum lung expansion. So that is a classical position. So we should not make the patient lie down because it may be very uncomfortable and intolerable to the patient. Good position. Put some high flow oxygen. Yes. Okay. What else? Any other thing that you could do? Come on. Go down. A, B, then?
Assess the circulation.
What I will do?
Status,
Do ABG.
peripheral cold or warm.
Okay, right, all right.
Blood pressures.
Monitor blood
Heart
pressure.
rate.
Yes.
Pulse volume.
What else?
Do ABG.
Yes, Lahiru?
ABG. You can do.
Hey, name the processing ke hiding again.
Do ABG.
It is still.
Clinically anemic.
ABG would be, we'll come to that. But before that, we'll come to that.
pale or not.
Okay. All right. Mhm.
And at the same time, we have to find out the underlying cause for the hypoxia. We have to treat it.
Okay, right. So tell me, what are you going to do? Yes. Okay. You are in the correct track. Tell me what I will do. Okay. So I check the pulse rate, volume. Somebody said the blood pressure. Okay. Then what I will do?
IV fluids. Give.
It is cellular. I will do tennis cellular.
IV access.
Get IV access. Get IV access. If not, get IV. IV access එක ගත්තාම ඊළඟ step එක මොකක් වෙන්න ඕනද?
Take blood flow investigation.
Take blood flow investigation. So in this case, a count would be helpful. If somebody said palo or whatever, yes, count. Then connect the drip. එතකොට steps තුන මතකයි නේද? කැනියුල එකක් දැම්මහම blood අරගෙන තමයි drip එක හයි කරන්නේ. නැත්තම් ආයෙසර fill කරන්න එපා. So those are the steps. Put a cannula, take blood and start a drip. කොතන ගියත් ඒ තුන තමයි පිළිවෙලට යන්නේ. හරි ලේසි, තරතර මිස් වෙන්නේ නැහැ. ඒ තුන මතක තියාගන්න. කැනියුල එකක් දැම්මොත් blood ගන්න තියෙනවා නම් blood අරගෙන තමයි then you connect the drip. So keep on oxygen, support the oxygen, the support the breathing if the breathing is not adequate. So A, B, C. But when you go to the C, then again you come to the A and C. How with the patient? How with the patient's oxygen saturation? How with the patient's the breathing? Is it improving or not? If you are happy only, then you go to the D and E. Right? Make sure there are any problems with the patient, any marks, wounds, right? So patient may not be breathing because of a laparotomy wound, or patient may be having some rib fractures or whatever. Right? Or patient may have developed a pneumothorax. We don't know.
Painkillers.
Sorry?
Pain is also painkillers.
Good. Very good. Right? So, okay, explore those things. D. Then you come to expose and see what are the other things. So remember A, B, C to start with. Before you go from A to B, make sure that you should have done something to A, then go to B. Before you go to C, then you should have done something to A and B before you go to C. That doesn't mean that A and B should be corrected before you go to C. No, you should start something and then go to the next step and come back and see whatever the things that you have started are working at the moment. A, B, C, A වලට මොකක් හරි abnormality දැක්කම you start something. ඒකේ ප්‍රතිඵල එනකන් ඉන්නේ නැතුව B වලට ගිහින් right? And you do something, and if you are still little bit concerned about A, then come back to A and see okay. A හොඳයිද කියලා. මේ දෙකම okay වගේ වෙනවනම් then you go to C. That doesn't mean it should be 100% correct. Right. Okay. So ultimately the answer should include. So you find out whatever the reason and then you treat accordingly. Right. Okay. So basic steps of managing hypoxia. So it's common to every emergency scenario. Not only that. Right. Okay. We'll move on. Tell me what is your experience about using oxygen in patients? Who are the patients that you have seen being given oxygen during your hospital experience? Tell me, one after the other. It may be medicine, surgery, gyneops, ped, psychiat, I don't mind. Yes.
Severe
Cardiology.
traumatic.
Okay.
Severe traumatic patients.
Okay, multiple trauma, right? All right.
Asthmatic.
So what are the medical indications of oxygen therapy? In medical wards? Okay. Patients with worsening of asthma would be, because they would be hypoxic, and then you will be able to use some oxygen to make sure the patients are comfortable. Okay, what else? Who are the other medical patients or medical ward that you have seen oxygen being given?
COPD patients.
Okay, patients with COPD, but worsening of hypoxia. COPD, you have to be careful because patients are hypoxic anyway, and they would be very happy to be hypoxic throughout their life. But if the patient's hypoxia worsens, then they will come to the hospital. Worsening of hypoxia, or worsening of the acute exacerbation of COPD. In that case, you could give some oxygen. But something that you must always keep it in mind is we should not overcorrect their hypoxia because they are very happy with hypoxia. Graded therapy of oxygen to the COPD patients? නැත්නම් ඒගොල්ලෝ මොකද ඒගොල්ලෝගේ අර මතකද they are on what is this called hypoxic respiratory drive. Carbon hypercapnia වල respiratory drive එක තියෙන carbon dioxide වැඩි වෙනකොට අපේ respiratory වැඩි වෙනවා. ඒගොල්ලෝ එන්නේ මේ hypercapnic throughout. ඒක නිසා respiratory center එක immune to hypercapnia. Then what they have done is they are respiratory centers are responding only to severe hypoxia. So they are very happy to be hypoxic. But severe hypoxia you have to treat with oxygen. But be careful. Okay, good. What else? Any other medical patient that you think would be helpful or benefited by
COPD thing?
Patients with lung fibrosis.
Lung fibrosis, okay, all right. So anyway, hypoxia, yes, but may not improve drastically, isn't it? Because there's a problem with the diffusion. Lung fibrosis can problem with the diffusion. Yes, okay. What else?
Pulmonary patients with pulmonary edema due to acute heart failure.
Yes, maybe because of heart failure, or maybe because of severe or massive MI. Yes, not all the patients with MI now will be getting oxygen because they are very happy to be. If the patients can maintain a saturation of more than 94 or so, then the current trend is not to give oxygen. You may have seen in your profited appointment or in the ETC appointment. Initially, when we were students and the trainees, all the time when somebody with MI, then oxygen is a must. But it's not the case at the moment, isn't it? Have you seen experience that type of situation? Physicians are a little reluctant to give oxygen. No? They may not give oxygen. If the patient saturation. Sorry?
COPD patients, is there range like to give oxygen?
Is there?
Is there range of percentage of oxygen we can give?
No, we are very happy to be your target should be about more than 88% saturation, right? So 88 to 92 would be more than happy. That's enough. How is that? Got the answer?
No, sir. I mean, is there such a percentage like you have to give 20% oxygen, or you have to give 60% oxygen, or 80% oxygen? Because there are in MCQs there.
No, we'll come to that. So the recommendation is if somebody is hypoxic and is a known patient with COPD and you know the patient's the exacerbation will lead to hypoxia, you could use the pulse oximeter, but best thing is go for a blood gas. Right? Go for a blood gas, which will tell you the exact correct saturation of the patient. So you would be very happy if the patient is having 88 plus of saturation. So what you do is, patient is now on 21% oxygen, but struggling. So you go for a next higher level of oxygen available that you could give, maybe about 28% or maybe about 35%, rather than straight away starting with 60% oxygen. High flow rates oxygen. So that is what we do in the COPDs, graded oxygen therapy. පාට ලොකු මේකෙන් පටන් ගන්න නැතුව පොඩි ප්‍රමාණයෙන් වැඩි කරලා බලනවා how is the patient response, clinical response එක හොඳ වෙනවා then we will be happy with that low oxygen till the patient is recovered. Would it be the explanation? Happy with that? So
yes, sir. Thank you.
Okay, so we'll do. Yes. So patients with worsening of asthma, acute exacerbation of COPD, but we have to be careful. Then patients with pulmonary edema, yes. Heart failure or massive MI, but remember, not everybody, but the oxygen saturation of more than 95, if the patient can't manage, then they will give oxygen, but otherwise they will not. Right, when it comes to surgical, yes, polytrauma patients, right? Some patients with, say, other medical problems like non-patient ischemic heart disease or valvular heart disease who have undergone major surgery, post-op, sometime you might have given some oxygen. Say, for example, some non-hypertensive or a non-ischemic heart disease. And you will give some oxygen, very small rate, the flow rate of oxygen, for the next 24, 48 or 72 hours, depending on the patient's cardiac compromise. Because it has been identified, the post-cardiac myocardial, the ischemia or infarction risk is highest in the first 72 hours post-op. post of මුල් දවස් 3 තමයි කියලා හොයාගෙන තිනවා වඩාත්ම risk වඩාත්ම dangerous in case for a patient to develop re-MI, re-ischemia, whatever. So ඒ කාලේ තමයි if you could give some oxygen support would be benefited. හරිද? ඒතර post op not everybody. හැම laparoscopy අපේ oxygen දෙන්නේ නෑනේ. You may have remember in your surgical appointments. But patients who had cardiac problems would have been benefited by giving some oxygen, depending on the patient's cardiac compromise as well as type of the surgery, the severity of the surgery or the type of the surgery. They might have given some oxygen for the 24 hours, 48 hours, or first 3 days post-op. Okay. So those are the basic types of indication that we commonly use oxygen, apart from post-op patients getting oxygen at the recovery, just to minimize the development of diffusion hypoxia. Right. Now we'll come to the other one. Happy with that?
Yes, sir.
Right. Okay. We'll move. What are the oxygen supply devices that we know of? So you can remember the oxygen is available in our hospital in different forms. Oxygen is available as gas in small cylinders available in the ward. දැන් තියෙන බෝඩ් එකේ තියෙන මේ පොඩි කාට් එක ඔක්සිජන් සිලින්ඩර් එකක් තියෙනවා නේද? පොඩි මේ ෆ්ලෝ මීටර් එකකුත් එක්ක. ඒකට කියනවා මේ බුල් නෝස් සිලින්ඩර්. බුල් bull nose. ඒ අර ෆ්ලෝ මීටර් එක කියන්නේ බුල් නෝස් කියලා. So it's a bull nose. අපිට ඒකට පුළුවන් the cylinder එකේ තියෙන්නේ full gas. ඔක්කොම cylinder එකේ තියෙන ඒවා gas. 100% oxygen pressurized. 100% oxygen pressurized. කොච්චර pressurized කරලා තියෙනවද දන්නවද? atmospheric pressure එක වගේ කී ගුණයක් pressurized කරලා තියෙන cylinder එක ඇතුලේ oxygen. අලුත් cylinder. Any guesses?
3.
නෑ ඊට වඩා අගක් වෙයි.
100?
ඊටත් වෙයි. It's about 137 times. එතකොට pressure එක බැලුවොත් ඇතුලේ cylinder එක ඇතුලේ pressure එක atmospheric pressure එක වගේ 137 ගුණයක්. අපි සාමාන්‍යයෙන් අපේ sea level එකේ pressure එක 0යි කියලානේ ගන්නෙ නේද? for measurements. නමුත් ඒකේ pressure එකක් තියෙනවා එකක්. එතකොට අපි cylinder එකේ pressure එක බැලුවොත් full cylinder එකේ pressure එක කොච්චරද කියලා බලුවොත් ඇත්තටම pressure එක පෙන්නන්නේ 137යි atmospheres. 137යි bar millimeters of mercury ගත්තොත් ඒ වගේ 760න් වැඩි කරන්න. right. හැබැයි ඇත්තටම cylinder එක ඇතුලේ pressure එක කීයද තමයි? අලුත් cylinder එක. මේකේ පෙන්නන්නේ මොකද්ද? dial එකේ පෙන්නන්නේ 137යි. ඇත්තම pressure එක we will see absolute pressure. gauge pressure එක gauge එකේ පෙන්නන pressure එක 137යි. absolute pressure එක කීයද හරියට? 100
138.
138. Very good. 138. ඇයි අපි sea level එකේ එකක් ඒකට add වෙන්න ඕන හරියට. So pressure දෙකක් තියෙනවා. gauge pressure and absolute pressure. අපි sea level එකේ අපේ දැන් බලුවොත් atmospheric pressure එක gauge pressure එක 0යි. absolute pressure ඇත්තම pressure එක හැබැයි 1යි. හරිනේ? absolute pressure එකයි. cylinder එක ඇතුලේ pressure එක 137 ගුණයක් වැඩි කරලා තියෙනවා. ඒතර gauge pressure එක 137යි. හැබැයි ඇත්තම pressure එක ගත්තොත් 137 එකතු කිරීම atmospheric pressure that is 138යි bar. Right? So when you use the oxygen cylinder, when you connect the patient to the oxygen cylinder, oxygen would be linearly drop the pressure. ඒතර patient oxygen cylinder එකේ gauge එක දිහා බලාගෙන dial එක දිහා බලලා කියන්න පුළුවන්. දැන් තාම full, දැන් භාගයයි, දැන් කාලයි කියලා කියන්න. And it will come to a red zone. අර dial එකේ තියෙන red zone, red part එක. ඒ හරියට එනකොට you have to make sure that you change the cylinder. මොකද oxygen කියන්නේ life saving එකක් නේ. ඒකත් එක මේ economy ගැන කතා කරන්න බෑ. So remember, when you become house officer, if you connect to oxygen using the bull nose oxygen cylinder, ඒක flow meter එකේ තියෙන dial එක pressure එක පෙන්නන්න cylinder එකට pressure එක 137 ඉඳන් අඩු වෙලා red zone එකට එනකොට remember, tell your nurses, tell your the ancillary staff, change it. Don't take unnecessary risks. හරිද? red zone එකට ගහම අයින් කරන්න ඕනේ. තව ටිකක් තියෙනවනේ තව චුට්ටක් පාවිච්චි කරමු බල බල ඉන්න ඕනේ. best thing is අතෙන්දල ඒක දිහාම බලාගෙන ඉන්න පුළුවන්. It will not happen every time, so you have to be careful about it. So oxygen is available in cylinders as full gas. What is the other source of oxygen available in our hospital? Vaccine.
Wall gas.
That again gas. Correct. You are correct. There are wall sockets available. There's a pipeline system laid in the hospital corridors. And from where those oxygen come from?
Oxygen concentrators.
We don't have oxygen concentrator, but that is one solution. Oxygen concentrator, yes, good. Oxygen concentrator කියන්නේ atmospheric air suck කරලා යවනවා earth silicate මේ එකක් ඇතුලේ the filter එකක් ඇතුලේ. So what will happen is that will absorb almost all the nitrogen. ඔක්කොම nitrogen ටික absorb කරගන්නවා. එතකොට ඉතුරු වෙන්නේ මොනවද? Oxygen, because environment layer carbon dioxide negligible, තව trace gases තියෙනවා like argon, but the bulk is nitrogen. So nitrogen would be absorbed, and you the adsorb to the molecules sort of earth silicates කියලා කියනවා. එතකොට you will get not 100% pure oxygen, but maybe about 95% plus oxygen. ස්ලීව් දෙකක් තියෙනවා. එහෙම දෙකක් සිලින්ඩර් දෙකක්. ඉස්සෙල් එක සිලින්ඩරයක් පාවිච්චි කරනවා. ඒක එක්සෝස්ට් වේගය යනකොට අනිත් සිලින්ඩරයට මාරු කරනවා. Right? So that's what we do. So you change over the other one. අනිත් සිලින්ඩර මාරු කරගන්නවා. So that's what we do. So මාරුවට molecular sleeve දෙකේ environmental air would be sucked. එතකොට oxygen source එක ඇත්තටම free. නේද? environmental air free නේ. cylinders නම් අපි oxygen ගෙන්න ගන්නවා. සිලෝන oxygen එකට කියලා ගෙන්නව ගන්නවා. සල්ලි දීලා ගෙන්න ගන්නවා. oxygen concentrate එක නම් ඇත්තටම ඉතින් මූලික වියදම විතරයි આવන්නේ. ඊට පස්සේ free. But remember, we will not get 100% oxygen. පොඩි මේ impurity ගතියක් තියෙනවා. Mainly it is because of argon. But it's a very good source. Oxygen concentrate. What else? අපේ hospital එකේ කොහෙද oxygen හම්බෙන්නේ තව? සිලින්ඩර් වලට අමතරව කරාපිටියේ.
Liquid oxygen.
Liquid oxygen. කොහෙද තියෙන්නේ?
Gate එකක.
එන්නේ. Where is this liquid oxygen device available in a hospital?
Cancer ward එකට යන පාර gate එක.
කොහෙද? Where?
Backside gate. Near the backside gate.
කොහෙද?
Near the cancer ward road gate.
කොහෙද?
The gate where the Highland.
Yes. කන බොන තැන් තමයි landmarks නේද? Right. Good. In front of the close to cardiology unit. You have seen there's a white cylinder available that contains oxygen in liquid form. So we could use a huge amount of oxygen as liquid. Mechanism එක තමයි මොකද mechanism? How you could make gas oxygen to liquid oxygen?
Pressurizing.
Anything. Oxygen cylinder වතුර වෙන්න බෑ.
By reducing the temperature.
However much you pressurize, it will never get liquid. You have to make sure you have to cool it. ඉස්සෙල්ලා cool කරලා ඊට පස්සේ pressurize කරනවා. cool කරන්නේ කොච්චරද?
-degrees.
What is the concept? හැම එකම minus වෙන්නේ නැහැ. What is the concept? Have you heard about a temperature called critical temperature? critical temperature.
Yes, sir.
That means that is the specific temperature above which, remember, above which the gas may not be liquefied, however much you pressurize it. So අනිත් පැත්ත මොකද්ද කියන්නේ? ඒකෙන් යට pressurize කරොත් gas එක liquid කරන්න පුළුවන්. හරිද? So that is the critical temperature. So different gas will have different critical temperature. The good example you may have seen is the critical temperature of nitrous oxide that we are using in the anesthetic gases. Nitrous oxide or critical temperature is 36. The room temperature is not very. Room temperature is nitrous oxide cylinder or nitrous oxide? As liquid. As liquid. Uda gaseous form එකක් තියෙනවා පොඩි, but majority is nitrous oxide. හැබැයි oxygen ඒ තරම් simple නෑ. The oxygen the cricoid pressure is in the minus range, as somebody said. It is about minus 118 degrees centigrade. 118 minus 118. Okay. So if you can lower the temperature, oxygen tank එකේ ඇතුලේ තියෙන temperature එක roughly about 140-150 minus centigrade. ටෙම්පරේචර් එක ඊටත් වඩා ක්‍රිටිකල් ටෙම්පරේචර් එක හොඳට අඩු කරාම ප්‍රෙෂරයිස් කරන්න ඕන හරි චුට්ටයි. ඒකේ ප්‍රෙෂරයිස් කරලා තියෙන්නේ up to a pressure of 5 to 10 times of atmospheric pressure. අපේ සිලින්ඩරය ඇතුලේ 137 ගුණයක් ප්‍රෙෂරයිස් කරලා තියෙන්නේ. ඔක්සිජන් ටැංක් එක ඇතුලේ ප්‍රෙෂරයිස් කරලා තියෙන්නේ maybe about 5 to 10 times. 7ක් කියලා මතක තියාගන්න මැද හරි. ඒතකොට critical temperature වල අඩු කරපු ගමන් අඩු කරන්න වැඩි වෙන්න මේ කියන්නේ අඩුව වැඩි කරන්න මේ වැඩි වෙන්න මේ පුළුවන් තරම් temperature වල අඩු කරන්න pressurize කරන ප්‍රමාණය අඩු වෙනවා. That's the important point to remember. දැන් වැඩි තියෙන මේ ගිනි අවුවේ කොහොමද අපි මේ temperature එක 140 minus තියාගන්නේ? So how will you do that? So what is the mechanism there?
There was ice.
කොහොමද හීතල දෙයක් රස්නේ වෙන්නේ නැතුව තියාගන්න පුළුවන් mechanism? Okay, අනිත් පැත්ත බලන්නකෝ. අනිත් පැත්ත කොහොමද කරන්නේ? රස්නේ දෙයක් හීතල වෙන්නේ නැතුව තියාගන්නේ කොහොමද?
Flask. By using a flask.
Flask කියලා දැන් මට flask හදන්න බෑනේ. මොකක්ද ඒකේ තියෙන mechanism? That's what I'm asking. කොහොමද? Insulation කොහොමද? Tell me. How you get the insulation in a flask? Yeah. What is the main mechanism in the flask to make sure the hot water is not getting cooled?
There is a vacuum space.
රික්තකයක් තියෙනවා කියලා මට. That's a vacuum. That's a vacuum. So the same mechanism is being used in the oxygen tank also. ඒක ඇතුලේ අපිට එළියෙන් පේන ලොකු සිලින්ඩරයේ ඇතුලේ නෙවෙයි ඔක්සිජන් තියෙන්නේ. ඊට ඇතුලේ තියෙන සිලින්ඩරයක් ඇතුලේ. container. ඒ දෙක අතර මොකද තියෙන්නේ? A vacuum. So somebody may have seen, noticed when oxygen comes at oxygen bowser එක ඇවිල්ලා ඔතන පුරවනකොට oxygen පුරවන ඔක්කොම පාර වහලා නේද වාහන අයින් is extremely cold. පේනවනේ එතන නේද? එතන තියෙනවා දැක්කම ඉංගලන්තේ වගේ හිමත් බැඳිලා තියෙන්නේ. අයිසුත් තියෙනවනේ මේ ගිනි දවාලේ. So big simply the temperature is extremely low. Extremely low. Concept is critical temperature එකක් තියෙනවා හැම ගෑස් එකකටම. ඒ critical temperature එකට වඩා අඩුවට cool කරන්න පුළුවන්. We can කරොත් pressurize කරපු ගමන් the gas become a liquid. So that is the simple mechanism available in the oxygen tank. The oxygen tank ඇතුලේ temperature about minus 140. The pressure is roughly about 7-8 times of atmospheric pressure. වැඩි හරියක් තියෙන liquid oxygen උඩ හරිය තියෙන පොඩි gas form එකක් gas phase එක. So එතනින් තමයි අපි hospital එකට use කරන pipelines පටන් ගන්න. So pipeline වල දෙන්නේ ඉස්සෙල්ලා it is heated. නැත්තම් අර patient ඇවිල්ලා ice cold මේ ඔක්කොම මේ පෙනහල්ල මේ ගල් වෙනවනේ හීතලේ. Right? So it will be heated. to room temperature before it comes to the pipeline. So you said three ways of providing oxygen in the hospital. Oxygen cylinders, pressurized full gas, oxygen concentrator, somebody says, very good. Then oxygen tank in the liquid form. So those are the sources of oxygen available to us. So when it comes to the hospital wall socket, the percentage oxygen available in those pipelines is how much? What is the percentage of oxygen available there?
100.
100%. It's 100%. Pure oxygen. It's 100% oxygen. But you can't ask the patient to keep his mouth on the wall socket, isn't it? There are different gadgets that we use, which you could connect one to the wall socket, other end to the patient, where you will be able to do some oxygen. So these are the gadgets that we are going to discuss now. Okay. If you see this one, give me 1 second, I'll come to this. Right, so this is something that we always use. Everybody may have seen it. Can you see it?
Yes.
Sir.
So it's a simple face mask. This is called MC mask, capital M, capital C. That is called medium concentration mask. Simple face mask. All plastic. So there's a methana wall socket eකට high කරන් තියෙන්නේ. එහෙම නැත්නම් cylinder with a flow meter. There's a plastic transparent line coming over here, connected, and there's a plastic face mask. Couple of holes are there. There's an elastic band. Head එකට පිටිපස්සෙන් දාගන්න. සමහර මාස්ක් වල මෙතන තියෙන පොඩි metal කෑල්ල මේ ගාන නහයට තද කරන්න පුළුවන් එකක්. metal bridge කියලා අපි එකට කියනවා. So mask එක නහයට තියලා කියලා ගානට තද කර ගන්න පුළුවන් තමන්ගේ ලෙඩාගේ නහයට උදාන්න. So this is a simple face mask. එතකොට මෙතන ඉඳන් මෙතන මේ pipe දිගේ මෙතනට යනකම් එන oxygen percentage එක කීයද?
100.
හා
100.
100%. එතකොට මෙතනට වෙනකම්. මම මේ මාක් කරන එක කර්සර් එක පේනව නේද ඔයගොල්ලන්ට?
ඔව් සර්.
Yes, sir.
Huh? Yeah. So pipe මෙතන ඉඳන් එන ඔක්කොම ටික මේ ටික 100% මෙතනට 100%. It's 100%. So it's, I think that's right. Thank you very much. 100%. That is 100%. එතන මෙතන තමයි ඔක්කොම වැඩි වෙන්නේ. So this is a very simple face mask. It's plastic and disposable. They're making infection but it's supposed to be disposable. But ideally it's disposable. So patient so he'll be breathing in and out. Exhale a patient carbon dioxide accumulate some amount of oxygen. And with the patient's next breath, whatever the oxygen coming from this route will be inhaled by the patient. එතකොට එන ඔක්සිජන් මෙතනට එනකම් 100% ආවට මේ arrow එක වෙනකම් පෙන්නුවාට 100% ආවට when this come to this part that 100% oxygen would be further diluted by the patient's expired gases. නේද? හරිනේ? So patient will not get 100% at all. Dilution එක අඩු කරගන්න පුළුවන් if you increase the flow rate. අපි 4ක් දෙන්න නැතුව 6ක් දුන්නොත් මෙතන oxygen flow rate එක මෙතන වැඩි. ඒතර patient ගේ expired gases වලින් මෙතන මෙන්න මේ mask එකේ reservoir එක ඇතුලේ dilute වෙන ප්‍රමාණය is less. ඒතර patient will get a higher percentage of oxygen in that case, depending on the flow rate and depending on the patient's the breathing pattern. If the patient starts breathing very rapidly, tachypneic, very tachypneic, එතකොට මොකද වෙන්නේ? dilution ප්‍රමාණය හොඳටම වැඩි. So in that case dilution would be low. Dilution එක වැඩි වෙන කියන්නේ patient ගේ breathe කරන fractional inspiratory concentration of oxygen, that is FiO2 would be low. Right? It would be low. So that is a problem. So depending on the flow rates, the percentage of oxygen patient could breathe would be changed. And different the occasions, the patient will change. You can't predict. Your patient is now on 40% oxygen, 50% oxygen, 60% oxygen. You never know. You can't calculate because it is ever changing. Depending on the patient respiratory effort or maybe the patient, the flow rate that you have adjusted. So you can't give a very the exact percentage of oxygen to the patient all the time. It varies. The fixed oxygen percentage of patient can go to the So other thing is this mask covers the patient's nose and mouth both. So what is the problem with that?
It forms some kind of irritability.
Possible. There's a possibility of irritation. What else? Come on. මේ මාස්ක තමන් දාගෙන හිටියොත් මූණ තමන්ට තේරෙන දේවල් කියන්න විතරයි. ඒ patient ට ඒවම තමයි ඇත්තේ.
Gas will come and deposit in eyes. Gas will come and deposit in eyes.
That is again, you will say patient will feel some uncomfortable, the feeling. Okay, all right, accepted. Anything else? It covers both mouth and the face, the nose both. So what are the problems in that case? I gave a clue now. Yes,
feeding, talking.
Yes, if you want to say something, say if you ask from something from the patient, if the patient want to say something, what he would do, he will have to remove the mask because it is very difficult to talk while the mask is on. The patients are not used to that. So what's the problem with that? If the patient want to eat something, drink something, can he do that with the mask? It's impossible.
No, they
have
have
to remove the mask. So what's the problem there? You may not be able to give
continuous.
Adequate.
Not adequate.
Continuous.
Continuous. You may not be able to give continuous supply of oxygen to the patient. So two problems that we say. Though it is simple, easy to use, disposable, the problems can't give fixed percentage of oxygen all the time. We may not be able to do continuous flow of oxygen. In case the patient want to talk or patient want to eat or drink, then the patient may have to remove the mask. What else? What are other problems? You think of the mask we said two problems. What else?
Drying of the nasal mucosa.
Yeah, that you said. Yes, okay, accepted, good. It may be uncomfortable feeling to the eyes, as somebody said, drying mucosa. True that. Remember that we connect the oxygen through a water trap, isn't it? Flow meter ඇතුලේ තියෙනනේ water trap එකක්. මොකද gases ඔක්කොම very dry gases stored. නමුත් අපි අර water trap එක කරා bubble කරලා තමයි එවන්නේ. Will that be a good humidification method?
Yes.
It's not.
Oh.
It's not a good humidification method, right? So that's the problem. So patient will have, that's why the patient will have very uncomfortable feelings. Especially if you increase the flow rate, the uncomfortability will be more. What is? So three things. Can't give fixed percentage, can't give continuous flow because the patient want to talk or eat, then they may have to remove the mask. And the patient may have some uncomfortable feeling, eyes, nose, nasal mucosa, as somebody said. Yes. What else? What is the problem? Having a mask on the face, what is the problem?
Patient is anxious. Patient is anxious.
Patient will be anxious. What type of patients would be anxious? That's the problem. Somebody who are not comfortable in closed spaces, they will feel similar type of the feeling when they are having something on top of the face. Right. So patients who are claustrophobic, having that experience of claustrophobia, might not be comfortable with that type of place. So he will say, මේක දාගත්තාම හුස්ම ගන්න බෑ, ඉන්න බෑ, කලබලයි, මේක අයින් කළා දාන්න, එතකොට මීට වඩා ලේසි කියලා. So he will make a fuss. Clear? But it's a very simple device. So we usually make sure that we give about 4 liters of oxygen. Metan tapi flow meter එක high කරලා මෙතනින් 4 liters දැම්මම patient will get roughly about 35%, 40% of F5. It will vary, but roughly maybe about 35. So this is more than adequate for a patient if you want to make sure the patient is susceptible for diffusion hypoxia in the theater. So recovery ki api oxygen දෙන්නේ මේ mask එකේ. With 35-40% දුන්නා හොඳට නැති to prevent diffusion hypoxia. So in the cold also you could use this one. It's very basic, simple. Right? But remember the limitations. Remember the limitation and how much of F5 that you will be able to achieve. Right? That is about 35 to 40%. Is it clear?
Yes, sir.
Okay, we'll go down. So that is simple phase. Then you have this one. මේ ඊතරේ මකන්න කියන කවුද අපේ යාළුවන්ට? Good, thank you. Right. So this is an nasal pump. And the oxygen is starting from here, end up in a loop. අර වගේ එක කොනකින් මාස්ක් එකේ වගේ එක කොනකින් නෙවෙයි ඉවරු. මෙතනින් ඉවර වෙන්නේ. End up in a loop. සිදුර කොහෙද තියෙන්නේ? 2 frogs like this. 2 frogs. අර සර්පෙක්ගේ වගේ 2 frogs. So nasal pump. මේ ප්ලාස්ටික් කෑල්ල පුළුවන් එහෙට මෙහෙට ඇඩ්ජස්ට් කරලා දැන් මෙතන දාලා ඇඩ්ජස්ට් කන දෙපැත්තෙන් දාලා මෙතනින් ගන්නට මුහුණ තද කරලා තියෙනවා. So you can adjust it. So what are the pluses, what are the minuses if you compare this with the face mask up? Okay. Tell me quickly 1 2 3 4 කියන ටක්.
Can use in claustrophobic patient.
Can be used. The patient will be comfortable with that. Good, that's good. They will be comfortable.
Can give as continuous.
Continuous flow. Kata free ne kata කරන්න පුළුවන් බොන්න පුළුවන් කන්න පුළුවන්. That's a good thing.
But drying of nasal mucosa is still there.
Is there. අපේ face mask එක නම් මතකද මෙතන පොඩි dilution එකට පොඩි reservoir එකකුත් තියෙනවා. Isn't it? There is no reservoir here. දැන් මෙතන reservoir ගන්න නැහැ. නහය ලොකුනොත් හොඳයි නැත්තම්. Right. Okay. So dryness of mucosa is there anyway. Yes. What else?
Can give more saturation
Can go?
than the mask.
Why do you say like this? Why is that? Any explanation?
Because there's no time to dilute with the exhale there.
Okay. Why do you say no time, less time?
Because there is no pool of air to be diluted as in the mask.
But there is no way of, okay. But the available space would be diluted with respiratory gases also. Isn't it? There's a small way, the space which would be diluted with expired gases. So your point may be correct, maybe not be 100% applied all the time. So if you analyze this, the amount of oxygen provided would be again roughly about 35%. Right? But there are a couple of pluses compared to simple phase mask. Anitya thamai, it is again a disposable one, transparent one, plastic. Transparent in if somebody started vomiting or whatever, then you will see it. Right? Transparent, so disposable, easy to use. Can be used in even claustrophobic patients, continuous flow of oxygen. The problems are it can cause dryness of mucosa. You can't predict the exact percentage, that you can't give fixed percentage of oxygen to the patient. It again varies, same like in face mask. So those are the mainly 2 problems with nasal mask. But it is a good choice, good alternative for simple face mask or the medium concentration MC mask. Okay.
Just by hunch. Do we want to give some more pressure or the force to put out the exhale gas from the nostrils while wearing this one?
There is a device called nasal CPAP. I don't know if they have seen it. That is, you give a positive pressure. මේ nasal bronch දැන් මෙතන තියෙන open නේ මෙතන එහෙම නෙමෙයි මේ prongs ටිකක් මීට වඩා දිගයි. They are called nasal catheters. ඒක දෙපැත්තේ තියෙනවා පොඩි cotton but the cotton hari මොන හරි එකක් දාලා you can the obstruct the two nostrils. You could give it with the under pressure. That is called nasal CPAP. There are nasal cannula, sorry, nasal catheters අපි use කරනවා. You may have seen it in, I think it is available in the medical ward. So you may be in the ETU, that might be available. Nasal CPAP. Next time, yes, your point is correct. But a simple nasal prongs will not have that the facility to give positive pressures. That is, patient has to breathe, but the whole breathing cycle will be under pressure. Continuous positive airway pressure, CPAP. Continuous positive airway, CPAP. Continuous positive airway pressure. Okay, nasal prongs. True, good. Any more question you want to ask? Otherwise, we'll move on.
So, increasing the flow rate, will that affect the delivering percentage of oxygen?
If you increase the flow rate, you'll be able to get higher percentage of oxygen, same like in face mask. Same like in face mask. But would be more uncomfortable, isn't it? Move would be more uncomfortable. But yes, possible. Yes, possible. Point is true.
So, what would be the maximum amount?
I think this nasal CPAP, sometimes they use, what they say is, I think about 10-15 liters per minute of oxygen flow they are using. But I don't know whether that same flow will be affected because it is very tiny tube, the nasal catheters would be going in. So that flow rate, I don't know whether there's real uncomfortable feeling to the patient. But that's what the manufacturers say. They can give about 10 to 15 liters of flow. High flow rates could be given using in nasal CPAP. But the simple nasal could be used. Yeah.
So then using simple face mask with 10 to 15 liters per minute?
You could. Then obviously the FiO2 would be more.
The FiO2
would be more. Still, it may be 60%, it may be 70%, it may be 50%. We don't know. That's the issue.
Okay.
That's another thing. Though it gives some comfort, we have to keep eye on this. But why should I say so? Because if it is misplaced, all the oxygen does not go to the patient.
What do you mean by misplaced?
Why should I say so? Because these nasal prongs are inside the nostrils. If I assume it is not inside the nostrils, then what happened?
So other place that it could go in, it can come down, isn't it? What else it could go?
Indeed, yes. Patient will desaturate.
In that area, true. Sometimes you may have seen board wala make high kala betanta podi plaster betanta podi plaster kala alawala thiya. So that means it is fixed. True, that your point is correct. You have to make sure that it is so accidentally, without noticing it, the nasal prongs may be ventilating the environment, not the patient's nostrils. True. Face mask kana hodara ragala peenamana vetticha gama. Yes, that's something. You could take it as a problem. Yeah. Good. That's fine. Can you move again? Move forward. Right. So next one. So you may have seen this. This is called high concentration oxygen mask. We have a simple face mask like before. But the addition is with the 100% oxygen through this pipeline. So through this tube. And additionally, it has a collapsible bag. It's a collapsible bag. As an oxygen, any patient with collapsible bag, oxygen connected. If you see it carefully, you will see which has a very basic unidirectional valve. Body rubber වැඩ කරන්නේ forward flow එකට විතරයි. මේ පැත්තේ තියෙන oxygen මේ පැත්තට එන්න පුළුවන්. හැබැයි during expiration මෙතන pressure එක වැඩි වෙනවා because of the exhale gases. අර පොඩි pellet එක වගේ එක වැහෙනවා. ඒතර expired gases මේ පැත්තට එන්න විදියක්. So during expiration what happens is මතකයිනේ we are giving oxygen continuously but patient is using oxygen intermittently. අපි හුස්ම ගත්තන් පස්සේ පිට කරන්නේ. Correct? So we give oxygen continuously, but the patient uses oxygen intermittently. ඒක නිසා expiration එකේදී අපිට පුළුවන් අර එළියට යන oxygen ටික bag එකකට එකතු කරගන්න. ඒ මේක හරි මැදට නේ. Inspiration එකේදී මේ oxygen patient ගන්නවා. Expiration එකේදී expire කරනකොට expired gases ටික මේ පැත්තට ඇවිල්ලා මෙහෙට එන එක වළක්වනවා. මොකද අර පොඩි මෙතන valve එකේ all those gases could leave out. මොකද මේ mask එකක්වත් tight fitting mask නෙවෙයි. නේ? Tight fitting mask. But as I said before, oxygen is continuously being given, knowing expiration එකේදී මේ අහකට යන oxygen ටික could be stored in the bag. එතකොට ඊළඟ ඉන්ස්පිරේෂන් එක පටන් ගන්නකොට patient පුළුවන් මේ බටේ දිගේ එන oxygen උයි මේකේ store වෙලා තියෙන oxygen දෙකම ගන්න. patient inspire කරනකොට negative pressure එකට මේ පොඩි valve එකත් automatically යනවා. So that is why it is called high concentration oxygen. Because of this, we may be able to give very high percentage of oxygen. Maybe about 70, 80, even 90% of oxygen, depending on the patient respiratory rate, effort. You got the mechanism? Right? And remember, the most important that remember, when you become a household, if you want to connect this one and you want to give high percentage of oxygen to your patient, right? Say somebody asthmatic, not COPD, asthmatic, you want to give high percentage of oxygen. Multiple trauma patient, you want to give high percentage of oxygen. Right? This is option. Use high concentration oxygen mask. Remember, before you connect the patient room, keep the patient's the face mask on the patient's face. මෙතන ඇඟිල්ල තියලා oxygen ටික ඇරලා allow this bag to half at least 3/4 filled. ඊට පස්සේ high කරන්න. එතකොට from the next breath you will see patient is utilizing oxygen coming from the wire, මේ tube එකේ එන ටිකයි as well as oxygen stored in the bag. නැත්තම් මේ බෑග් එක පිරෙන්න යනවා සෑහෙන වෙලාවක්. එතකම් patient ගන්න වෙන්නේ මේ oxygen ටික විතරයි. ඉතුරු oxygen ටික ගන්න වෙන්නේ එන්නේ. Okay? So that is the most important to remember. High concentration oxygen mask. Make sure that you fill the bag before you connect it. Remember, මේක collapsible නිකන් කුඩු වෙලා පුපුරලා යයි. ඒක කල්පනාවෙන් පුරවන්න. Got the point? The same advantages are there. Simple, easy to use, disposable. The problems are claustrophobic, dryness of the mucosae. Patient you may not be able to do continuous flow because it has to be removed when you talk, when the patient starts eating or drinking. Right? And the biggest issue is prove that we can give high percentage of oxygen. Prove that we can give high percentage of oxygen. Still we don't know how much of oxygen patient would get at a particular moment. That's the point. So we don't know the exact FiO2 at any point. But we do know the patient would get very high percentage of oxygen. That we know. Okay? So 3 simple things. Face mask, modification is high concentration oxygen mask and nasal box. Any question you want to ask from this? Otherwise we'll go quickly move. Right, okay. The next one that we are using is a venturi. Again, a modification of face mask. Method 100% oxygen, connect the face mask. And it has a gadget here. Different color code. You can compare the part of so there's no universal color code. You can get a specific percentage of oxygen. The mechanism here is මේ white tube එකේ oxygen ඇවිල්ලා මේ white tube එකේ oxygen මෙන්න මෙතන expose කරනවා to a tiny tube. දැන් මේ white tube එකේ oxygen ටික ඇවිල්ලා it will be exposed to a tiny tube. මේ tiny tube එකට තමයි. So what will happen is මේ freely ආපු කට්ටිය මෙතනට ආව මොකද වෙන්නේ? හරිම කලබල. Everybody wants to go through this narrowing at first. නේද? ඒකනේ method එක. ඊට පස්සේ මොකද වෙන්නේ? narrow එකකින් ගිහිල්ලා then exposed to again a wider tube. What people have noticed was මේ narrow tube එක යනකොට ඇත්තටම narrow tube අපි හිතන්නේ narrow tube එක ඇතුලේ pressure එක වැඩි කියලා. But what really happens is the pressure is low. මොකද physical principle එක තමයි when the air molecules are moving, it has two forms of energy. Two forms. One is called the kinetic energy, which needs the movement of forward flow of gases, the air molecules or the gas molecules. That is called kinetic energy, which needs for the movement. The next one is the potential energy, which is stored in the air molecules. Method everybody needs more energy to pass through. The kinetic energy the kinetic energy so what from where kinetic energy would take? Additional kinetic energetic air molecules potential. In this case, oxygen molecules stored potential energy. අපි measure කරන්නේ මෙතනට pressure gauge එකක් දාලා බැලුවොත් අපි measure කරන්නේ මෙතන not the kinetic energy, the energy or the pressure in the molecules. එතකොට kinetic energy අර potential energy ටිකක් ණයට ගත්ත හින්දා ඇත්තටම potential energy අඩු. That is what we are going to measure. So මෙතනට pressure gauge එකක් high කරොත් you will notice it. Pressure here is high, but the issue that we find is the pressure in this narrow tubing is low. The mega jet මොකද කරන්නේ narrow tube එක ළඟට heel ටිකක් හදලා තියෙනවා. Pressure අඩු වෙනද මොකද වෙන්නේ? Using these holes, what can happen? Environmental air can go in. එතකොට මෙතන pressure එක ගන්නවා මේක ඇරලා තියෙන හින්දා environmental air මේකට සක් වෙනවා. If you get a 10 liter flow rate here, may differ depending on the gadget device, you may be able to create a flow rate of about 30 to 35 liters per minute of flow here. So a flow rate is too much for the inspirative flow rate. අපි හදාගන්න peak expirative flow rate කියලා ගන්න ඉතින් asthma එහෙම කරලා අපි treat කරනකොට බලන්නේ whether patient is responding, because asthma is a disease of expiration. Peak expirative flow rate. Here what we are doing is peak inspirative flow rate. So inspiration එක ඇතුලේ කොයි වෙලාවකවත් peak inspirative flow rate එකට වඩා වැඩියෙන් නම් අපිට හම්බ වෙන flow rate එක. There is no point dilution. Healthy කට්ටියගේ peak inspirative flow rate එක roughly about 30 liters per minute. Per minute. Remember, per minute. හැබැයි අපේ expiration එක තප්පර ගණනක් තියෙන්නේ නේද? අපි විනාඩියක් ගත්තොත් අපේ breathing rate එක අපි 12යි කියලා. හිතන්නකො rate එක 10යි කියලා to make it a easy calculation. So if your respiratory rate is 10, so each respiratory cycle will take 6 seconds. වෙදීම 10. ඒ එක cycle එකක් will include inspiration and expiration phases. What is longer, inspiration or expiration? Question from you. What is long, inspiration or expiration? Neither. What is wrong in your being? Looks like most of people are apneic. Come on. Who will be? Yes. No
Inspiration.
Answer. Is it? Inspiration or expiration? It is expiration which is prolonged.
Inspiration.
It's expiration which is prolonged. ගෙදර ගියාම හුස්ම නම් බලන්න. So roughly it is inspiration එක වගේ දෙගුණයක් විතර යනවා expiration with the pause. Inspiration වගේ දෙගුණයක්. So calculate කරලා බලුවොත් if your respiratory rate is 10, one respiratory cycle will take 6 seconds. Like inspiration එක ගත්තොත් එහෙනම් roughly about 2 seconds. Expiration is roughly 4 seconds. තප්පර 2යි තප්පර 3යි අපි සාමාන්‍යයෙන් හුස්ම ගන්න. එක පාරකට. නමුත් flow rate එක කියන්නේ අපි මිනිත්තුවකට. ඒත් හිතාගන්න පුළුවන් අපි 30 liters per හුස්ම ගන්නෑ. Almost small liters ප්‍රමාණය දශම ගණනක් තමයි හුස්ම ගන්න. But the flow rate is very high. So what this gadget would have done is they have trying to give a percentage of oxygen, 100%, diluted with fixed amount of gases, 21% oxygen, depending on this narrowing, and we'll get a huge flow rate of FiO2 pre-calculated. මේක එක size කැලි දැම්මහම ඒකට අදාළ flow rate එක අපි යවුවොත් 100% oxygen මේ narrowing එක හදලා තියෙන්නේ මෙච්චර 21% oxygen ටිකක් entrain කරගන්න මේක ඇතුළට. ඒවා fixed. ඒවා lab එකේ පරීක්ෂණ කරලා හොයාගත්ත ඒවා. මේ flow rate එක අපි මේ කියන flow rate එක මේක ඇතුළෙන් දැම්මොත් මේ narrowing එක හදලා තියෙන්නේ in such a size by the factory, and this will create a huge volume of flow of environment, and 21% oxygen would be sucked in and will make 30 liters of gas mixed with 100% oxygen coming over here. That flow rate is more than adequate to prevent any further dilution by the patient's expired gases. The dilution is a minimum. ඒක නිසා මෙතනට එන ඔක්කොම මේ fixed percentage එකම would be taken over by the patient. So this is called a Venturi mass. The principle එක අපි කියනවා Bernoulli කියලා. But the Bernoulli principle එක use කරලා තියෙන්නේ Venturi mass එක. Right? So this one, if you go to the HDU Ward 5, we'll have this is 60% oxygen. If you want to get 60%, the flow rate to be adjusted is 15 liters. ඒ දෙකම මේක ලියලා තියෙනවා. එතකොට patient high කරන් පස්සේ අපි මෙතනින් 15 liters මේ size එකේ මේ flow මේ entrainment මේ tube එකේ narrowing එක හදලා තියෙන in such a way it will suck in about 15-20 liters of 21% oxygen. That is environmental air. Right? So this is 60%. I think this is 40% if I don't remember. 35. 40%. Can't remember exact the values. You should never remember it because it is named. It's the mark. Okay, mark kala tiyenne percentage එක, the percentage that you will get, and to achieve that percentage, how much of flow rate that you have to adjust කියන එකත් මේ ලියනවා. So the advantage is, biggest advantage, we could give a fixed percentage of oxygen throughout the patient, irrespective of the patient's respiratory effort. අනිත් තුනේදීම අපිට ඒක ලබා ගන්න බැරි. But all the other problems common to face mask and high concentration face mask are here, right? Because it is a face mask again, right? So it's a Venturi. So this is called a fixed performance device. All the three that we have discussed before are called variable performance also. Correct? Right. So we move. කොහොමද ස්ක්‍රීන් එකේ resume share assume use share නේ අපිට control ඕනේ. Anybody who knows how to commit from the normal screen again? Yeah.
So on the top of the screen, there may be a
on the top of the screen?
On the top of the screen.
Oh, මොනවද තියෙන්නේ?
There may be like a tab coming up.
මේක නෝ මේන්නේ හරි මේක ඊට පස්සේ ඒකේ
Leave options and then exit full screen. Like
leave
leave, no, not leave, sir. Like exit or something.
hide video panel, hide the video show names, disable participation, record chat, optimize. ඊතරෙත් මේ වැඩේ වුණා මට. Participant, stop video, mute, new share, resume share බලමු. මේක නෙවෙයි. ඒක නෙවෙයි. ඒක මොකක්ද තියෙන්නේ? Remote control, chat. නෑ chat නෙවෙයි. Anyway, මම පේන්නේ නැතුවද නේ?
We can see you anyways.
Fair enough. Right, okay. So we'll go. So we have now discussed a couple of things, how to give oxygen in the wards. Simple face mask, that is MC mask, nasal prongs. Then modification of face mask is high concentration oxygen mask. Remember to fill it back before you connect it. And the last one we discussed is the device that we could give fixed percentage of oxygen. That is Venturi mask. Right? Okay. Right, all right. So the next topic that we are going to do is few things about the hyperbaric oxygen therapy. Right? What are the indications for hyperbaric oxygen? Any idea?
Monoxide poisoning.
Carbon monoxide poisoning. What else?
Barotrauma.
Clostridium perfringens infection.
Right. Barotrauma would be probably a complication, isn't it? Carbon monoxide poisoning. What else?
Clostridium perfringens.
Any.
Gas gangrene.
Yes, arterial gas gangrene. What is the other common thing? Not in hospitals, but sometimes we yes. To minimize the effects of decompression sickness. Hyperbaric oxygen means you could either give air or oxygen more than the atmospheric pressure. Usually we use 3 atmospheric. More than 3 would be unsafer, but we use 3 atmospheric pressure under the pressurized chamber. So hyperbaric oxygen, right? So main 3 indications: decompression sickness. Then what there would be the, as you said, carbon monoxide poisoning. And third one is arterial gas gangrene. In addition, there are a couple of other indications sometimes people will use. You may have heard about the hyperbaric oxygen is being used for in non-healing ulcers sometimes. Diabetic wounds. You may have heard about anaerobic wounds, like specifically these clostridial wounds. Anaerobes will be getting destroyed by the high percentage of oxygen. The radionecrosis, osteoradionecrosis, fractures, the radiation injuries, we use increased oxygen available to remove the things, right?
So is it used
then
for
sometimes you
pregnancies?
could use in severe anemia sometimes, right? But 3 common the scenario that we use: carbon monoxide, decompression sickness, and the third one is arterial gas gangrene. So those are the 3 things. Okay. So we use under pressure, less than 3 atmospheres, right? More than that would be dangerous. And what we are going to achieve is, by increasing the pressure, what component of oxygen delivery system is improved. You can remember we had 2 ways of the transporting oxygen. Dissolved, yes. You increase the dissolved. So by increasing the pressure of oxygen, we increase the partial pressure of arterial oxygen, and thereby we are going to increase the dissolved fraction. It has been found out, as I said before, usually if you breathe 21% oxygen at rest, your dissolved fraction of oxygen would be 3 ml of oxygen per each 100 ml of blood. But by using 3 atmospheres oxygen, you would be able to increase it to 60 ml of oxygen dissolved in each deciliter or each 100 ml of blood. So irrespective of hemoglobin, we may be able to provide the adequate oxygen for tissues by just increasing the pressure. Right? So that is the purpose of using the high percentage of oxygen, especially in the clostridial infections, then the non-healing wounds, all those things we are using that mechanism, increasing the severe anemia, increasing the amount of the dissolved fraction in the. But increasing pressure will be used, especially in gas gangrene, arterial gas gangrene, as well as SCUBA, the decompression sickness. You can remember in your physiology, the decompression sickness, indeed. The nitrogen available in the tissues and blood would be squeezed, that bubbles would be squeezed when you go under water because of the high pressure. But if you suddenly come up, that squeezed gas bubbles would be suddenly expanded in the tissues and blood. That gas bubbles will even block the peripheral organ perfusion. It can cause the lot of mild, it is headache, joint pains, tissue pain, the limb pain and all those things. But if it is worse, it can cause even the myocardial infarction because the blockage of vessels by the nitrogen bubbles in the heart. Brain can lead to strokes. Right? So it is mild to fatal depending on that. It happens if you come up rapidly. So if it is the decompression sickness, the management should be immediate. Patients are taken immediately. So that is why this, especially we have one, I think, available in Trincomalee camp, I suppose. Right? If at the use in our country, right? So which will make sure you put the patient into a chamber and pressurize. Right? So then we can make the gases squeeze again till get gases dissolved slowly. Right? So there are two ways. If you remember, I just got two pictures for you. So there are two ways. One is single chamber, where one patient is put to this plastic tube, transparent tube, pressurize කරනවා. Right? Or else multiple chamber. That time මේක කට්ටිය වාඩිලා ඉන්න සමහරට හාස්‍යලා දෙනවා. ඒගොල්ලන්ට head hook මේකක් දාලා තියෙනවා. Head මේක and the chamber would be pressurized. Right? Or sometimes if you can make it fixed, then only this part would be pressurized. And that would be measured from outside. So issue එක තියෙන්නේ in emergency somebody can come in. මෙතනට වගේ එකපාරට හදිසියකට එන්න බෑ. මොකද මේක ඇරලා ගොඩක් වැඩ කරන්න එපා. This is much safer. It's a multiple chamber. High hyperbaric oxygen treatment. Right? So remember the aim is to make sure we pressurize, thereby we increase the partial pressure of arterial oxygen, dissolved fraction available in the body. Right? And we pressurize. Right? So it's being used in decompression sickness, carbon monoxide poisoning, and gas jet. So those are three common things. Right? What it would do in addition, right? So high percentage of hypoxia might cause improved in the blood vessel formation. That's a possibility. It can kill anaerobes. That's why we are using in severe anaerobic infections. Right? It can improve the neutrophil function because of the high oxygen available, and it will improve the killing of bacteria and other germs. Right? So that type of additional advantages available with hyperoxic condition. But there are a couple of dangers. Right? High pressure can cause problems. It can cause barotrauma, as somebody said. It can burst the lungs. It can cause ear damage, rupture. It can cause headache, nausea, vomiting. But other than that, some people will get features of oxygen toxic that we are going to do next. Right? Features of oxygen toxic. And most important, simple one is if you use high percentage of oxygen, always there's a risk of fire. Right? Always a risk of fire. So it's a hyperbaric oxygen. So, few words about it. Right? Is it clear? Oh, you got
Yes.
some idea about the hyperbaric oxygen therapy? Remember what
Yes,
are the
sir.
indications, how we could give it, and what are the complications. Right. So that is about hyperbaric oxygen. The last part that we are going to do is the side effects of oxygen. We know oxygen is helpful, is alive via in the survival. But oxygen is not safe all the time, isn't it? So what are the complications of oxygen therapy? One after the other? Yes. What are the problems?
Oxygen
of oxygen?
toxicity.
Before that, simple issue. Common
Depression
problem.
of ventilation.
Sorry, Evne.
Depression of ventilation.
That's possible, yes. That's possible. Especially not normal, not everybody. Especially with people with COPD.
COPD.
Yes, that's remember. That's why we said at the beginning, if you are treating hypoxia in a COPD patient, you have to make sure that you are giving graded oxygen therapy to prevent patient is unnecessary hyperoxia or overcorrecting hypoxia is dangerous. Patient can cause the respiratory depression. Yes, okay. What else? As this is that the simplest impact is fire. Oxygen, fire. So it can depress the respiration. What else? Rather than breathing oxygen and nitrogen like atmospheric air, if you use higher percentage of oxygen, denitrogenating the lung, what is the other effect? What are the advantages of having nitrogen available in the atmospheric gas for our respirators, even though we are not using it? Any idea? What are the advantages of nitrogen? Yes, what are the advantages of nitrogen available? Anybody that you could think?
Prevent athletics.
So the nitrogen has action like surfactant also, which will prevent collapse of the alveoli. Nitrogen දිගටම තියෙනවනේ පාවිච්චි කරන්නෙත් නැහැ ඔය තියෙන. So that will help to make our alveoli patent or expand. So denitrogenating the lungs, there is a risk always the alveolar collapse. What areas of the lung are more prone or vulnerable? What areas of the lung are more vulnerable?
Apical region?
Sorry? Apical, middle or base?
Base.
Base, it is base. So that's a possibility of lung collapse, especially at the bases. That is called absorption atelectasis. So you give nitrogen to make sure the patient's oxygenation is better, but there's a possibility the lungs can get collapsed if you unnecessarily denitrogenate lungs. Right? So fire is a possibility, respiratory depression is a possibility, especially with COPD patients, if you overcorrect the hypoxia. Absorption atelectasis is a problem. Any other issues? You may have heard about in pediatrics, the
Retinopathy and prematurity.
Yes, you can go to blindness. So that is why you may have remember if you are doing pediatric appointment, going to the NICU. These small premature babies are frequently referred to the eye surgeon because they can't complain of their vision is poor. So it is our duty to make sure check the retina routinely because patients are on long-term oxygen for whatever the problem that they had at birth. To make sure the eyes are checked frequently under anesthesia. And if found, treat accordingly, especially with laser. Retinopathy of premature to prevent blindness. Yes, good. What else?
Bronchopulmonary dyspnea.
Sorry?
bronchopulmonary dysplasia?
How? Is it there? It's not a complication as far as I can remember. Any other things? Somebody said also. What is the other one?
Oxygen toxicity.
Oxygen toxicity, yes. Oxygen toxicity. Usually the recommended is 40% oxygen is safe indefinitely. 21% is anyway safe. Oxygen toxicity. So 21 is anyway safe, but we are discussing about extra oxygen. So 40% of oxygen indefinitely is supposed to be safe. But beyond that, if you increase the flow rate, depending on the exposure, the duration of exposure, there's a possibility that it can cause oxygen toxicity. Right? Oxygen toxicity will affect each tissue, every tissue. It may be heart, it may be brain, it may be lung, the respiration, it may be the bone marrow, it may be the kidney, it may be the liver. Anything is possible. But two common systems are used to affect. It is central nervous system and the respiration. Respiration system, you will see it's something like a ARDS type of a picture. Patients are dyspneic, tachypneic. They will complain of pleuritic type of chest pain. They will have increased cough. And when you take a chest X-ray, you will see multiple whitish opacities. Right? Same like type of ARDS. Central nervous system, commonly, right? You will have, especially the cranial nerve features. They will have visual changes, diplopia, the color vision, and commonly they will have the tunnel vision also. Peripheral visual fields are slowly getting affected. Tunnel vision is a feature of oxygen toxicity. Right? In addition, they will have, say, hearing changes, tinnitus, muscle twitchings, and if you not detect it, go into even convulsions, and patient might get coma also, end up in comatose state. So those are the two things. In the bone marrow, because of the oxygen, the free radicals can damage the cells because rapidly developing cells, right? Patient might end up in anemia, agranulocytosis, or whatever. Right? Hepatic damage, renal damage, right? So every system could get affected, but commonly manifested in respiration and central nervous system. Okay. Any antidote or any management option? So what can we do? There's no antidote, anything. What you could do is try our best to reduce oxygen as early as possible. So how can we reduce oxygen? Make sure patients give oxygen just to make sure to survive the patient. Right? So what you could do is, rather than titrating oxygen to make sure the patient's oxygen saturation is always 100%, you try to saturate the titrate oxygen to a saturation of say 88%, 90%, 92%, which will just make sure patient would survive with that oxygen saturation. Low targets. Go for low targets. Thereby you will be able to reduce the oxygen percentage that you will be able to give to the patient. There are a lot of other mechanisms. Rather than just giving oxygen, you can use non-invasive ventilation. You may have seen the medical wards, BiPAP mask, CPAP mask. There are a lot of non-invasive ventilating modes available in the ICU. If not working, you can go for invasive ventilating methods, but providing less than 7% of oxygen. So that's what we do. Okay. Right. So that is the end. Anything you want to ask from me? Any questions before we wind up?
Oxygen saturation measurement by pulse oximetry. What are the factors that depend on, whether it depend on the anemia or the age of the patient?
Pulse oximeter, it will depend on the first important that you remember. It depends on the peripheral circulation. හිතන patient හොඳටම hypothermic කියලා, එහෙම නැත්නම් hypovolemic, එතකොට peripheries are vessels are constricted. එතකොට peripheral flow එක නැතුණාන් පස්සේ the pulse oximeter may not be able to detect the peripheral arterial blood flow. ඒක තමයි analyze කරන්නේ. The peripheral flow එකක් තියෙනවා pulse oximeter to work. That is one thing. Sometimes අර ඇඟිලි පාට කරලා තියෙන nail varnish වගේ දේවල් will affect the pulse oximeter reading. Right? සමහරවිට පරණ pulse oximeter තියෙන ඕනට තියටර් එකේ light එක වැඩි වුණොත් ambient light එක වුණොත් pulse oximeter reading එක ටිකක් upset වෙනවා. That is something that you are doing. Some dyes in the bloodstream might affect the pulse oximeter, especially this methylene blue and things. Not the bilirubin. The jaundice will not affect, but some artificial dyes like methylene blue might affect the pulse oximeter. Sorry? Okay. Happy with that answer?
So then what about anemia?
Anemia means that whatever available oxygen, anemia is not the issue. See, even the patient's hemoglobin is 5, if the patient, that 5 may be fully saturated. Patient would be hypoxic. The rest එක සමාන hypoxic වෙන්න තියෙනවා. But what the pulse oximeter would measure is not the hemoglobin concentration. Hemoglobin concentration එක නෙමෙයි pulse oximeter මනින්නේ what is the percentage of available hemoglobin saturated with oxygen.
Okay, sir.
Understand my point?
Yes, sir. Yeah.
එතකොට anemic තියුණා කියලා you will get a saturation of 100%. It's false reading then. සමහරට met hemoglobin වගේ දේවල් තුනත් හරිම odd values එනවා. Maybe about our fixed 85-86% oxygen saturation මේ patient හොඳට ඉන්නවා. But there's the problem with the analysis, especially with met hemoglobin. Right? So it's a fixed reading, 85% වගේ fixed reading එකක් වෙනවා හැමෝම. So those are things which can get affected by which affects the pulse oximeter reading. Not the hemoglobin concentration itself. Okay, any more? Okay, stay on program. Right, then thank you very much for participating. Hope that you got some points. It would be helpful in the morning. Thank you very much for your participation. Okay.
Thank you, sir.
So I am
Thank you,
leaving
sir.
then. Okay.
Thank you, sir.
Thank you.
Yes.
Thank you everybody.
Thank you, sir.
මට මේක දාගන්න බැරුණා ඒ තාම. ඔව් අපි උදව්වට ගන්නවා. Oh no. Right, okay.